They are able to cause tumor cell death by binding to and blocking two necessary growth factor signaling pathways for tumor cell survival. So that's going to be kind of dependent on the target of the antibody. I'll give an example of EGFR, or epidermal growth factor. This is overexpressed in several different kinds of cancers where activation of this growth factor increases the amount of proliferation and migration of cancer cells. So if we bind to it and block to it, then that would help halt these pathways and stop cancer cell growth.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Carissa Ganihong, Oncology and Bone Marrow Transplantation Clinical Pharmacist at Hackensack University Medical Center in New Jersey, about monoclonal antibodies. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. As a reminder, this episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the episode notes. Welcome and thanks so much for joining us today, Carissa.
Thank you so much for having me.
So to start things off, what exactly is a monoclonal antibody? And could you give us maybe a brief overview on the history of this drug and how it's performed in the field of oncology?
Before I jump into the details, I just want to say that the views and opinions expressed in the podcast are my own and not affiliated with Hackensack University Medical Center or Hackensack Meridian Health Network. Before going right into a monoclonal antibody, I just wanted to briefly discuss what an antibody is. Antibodies, which are produced by B cells that we have floating around in our systems, they're really, really very diverse. They're really key components of our immune system, but there are many different types. They're able to recognize a really expansive variety of targets or antigens. Antigens just being any molecule that the immune system is able to recognize and trigger an immune response. When we're referring to the mix of the many type of antibodies that we have, these are referred to as polyclonal antibodies, with the prefix poly meaning many. So when we're just referring to a monoclonal antibody with the prefix mono, we're just referring to a single isolated type of antibody. When we're thinking of our therapeutics, it's just many, many copies of the same exact clone, the same exact type of antibody. For the antibodies, monoclonal antibodies we're referring to today, we're specifically talking about their uses in therapeutics. But when I was researching the history of this topic, specifically and how they manufacture these monoclonal antibodies, something I found really interesting or maybe even ingenious for the time was that there is a type of malignancy where we think of having abnormal monoclonal antibodies as a pathological process, that being multiple myeloma. This is when you have plasma cells that only produce a single type of abnormal antibody clone. And so one of the first methods by which they were actually made therapeutic monoclonal antibodies was actually produced by fusing an antibody-producing B cell with a myeloma cell, allowing that cell to now proliferate indefinitely. And that was called a hybridoma. So I thought that was something that was very interesting.
That is absolutely fascinating.
Yeah, definitely interesting that they're taking advantage of this cancerous cell to make a therapeutic. So going back more into the actual history, the monoclonal antibody market has definitely really exploded over the years. The first ever monoclonal antibody approved by the FDA was actually not for an oncologic indication. It was a drug that was approved for transplant rejection called maromonab, and that was approved back in 1986, though it's now been pulled off market with the development of safer drugs. And then in thinking back to the world of oncology, prior to monoclonal antibodies, all we really had were these toxic chemotherapies, toxic radiation. So it was recognized and how great it would be, of course, if we can have a treatment that was much more specific to the tumor cells and to have agents that have ideally less toxicities. And so these advancements in the monoclonal antibody production really began in the 80s, the 1980s. There were some phase 1 and 2 studies that were conducted of the monoclonal antibodies, mostly in leukemia and lymphoma disease states, typically using that hybridoma technology. And then over time, they've developed new kinds of technologies. And eventually we had the first monoclonal antibody that was FDA approved for an oncologic indication. And this drug was rituximab. This was approved in 1997, and that really revolutionized the management of our B-cell lymphomas and is also really widely used in also the world of immunology or rheumatology. And then later on, now we have even newer technologies where we're able to use monoclonal antibodies to deliver chemotherapy in a bit more targeted fashion. So we have something called antibody drug conjugates now, where the monoclonal antibody is able to find their target. And this antibody is linked to what we call a cytotoxic payload. And once it goes and finds its target cell, the whole drug conjugate is taken in and internalized by the target cell, where the linker gets dissolved and it releases that toxic chemotherapy. And so the first ever antibody drug conjugate that was FDA approved was gemtuzumab ozogamicin back in the year 2000. Although this drug has its own complex history where it was taken off the market and went back on market, but that was the first ever FDA approved antibody drug conjugate. And now we even have more different kinds of therapeutics. There's monoclonal antibodies linked to radioactive isotopes. We have bispecific antibodies where monoclonal antibody is able to recognize two separate targets. So when I was just looking into statistics as to how many of these therapeutics do we have now, from 2023, there are about 170 monoclonal antibodies available, of which roughly 65 were for cancer indications. So today, we can only imagine there's even more, where we feel like every other FDA approval is some kind of monoclonal antibody in nature.
Those numbers are really staggering, but not really surprising. As we prepared for this episode, I was like, surely we've had one on monoclonal antibodies already. But as you just completed that response, it's like, well, we've talked about maybe some of the subclasses, and we'll kind of get into that a little bit later in our discussion as well. But looking at it from a slightly higher level of just maybe they're all monoclonal antibodies to start with. And before we get into more details, let's just pause and talk about the bigger class. And so that's what we'll do today. Let's talk a little bit about how these drugs are named, because it can give us clues and understanding of really what's inside this monoclonal antibody.
Whenever a new drug is approved, it's always funny how the names can be so complex. And it always feels like there's maybe no rhyme or reason as to how they're naming these drugs. But actually, there is a whole organization dedicated to naming these drugs called the International Non-Proprietary Names Program, which is actually part of the World Health Organization. They do have some methodology as to how they're naming monoclonal antibodies. Typically, what we'll see is that the monoclonal antibodies will end in the stem MAB for monoclonal antibody. Some examples, of course, rituximab, trastuzumab, daratumumab, and so on. And then immediately before that MAB component, there's going to be 1 to 2 letters that distinguish the source of the antibody. So like I mentioned before, the initial technologies that we had for developing monoclonal antibodies, they use this hybridoma technology, but this was really from kind of like a mouse or murine source. And so to denote that murine source, they would use the letter O. So for example, blinatumomab would be a murine source. And then later on, the technology evolved. Like I mentioned, there's different sources that were developed, and they wanted to kind of develop different sources because the murine-based monoclonal antibodies, they have so many foreign proteins to us that it led to a lot of immunogenicity, lots of side effects, and greater risk of hypersensitivity reactions. So now we have kind of more humanized or human forms of sources. One of the infixes is XI, which means it's a chimeric monoclonal antibody. That means it's about the 70% human. So an example is rituximab. And then we have ZU, refers to a humanized monoclonal antibody. This means it's entirely human, except there's just one little component that is still of murine origin. And then you have the letter U, which just denotes it's fully human. An example of that would be something like nivolumab. And then these, again, are less immunogenic than the original murine source of monoclonal antibodies. And so that's kind of the last 4 or 5 letters. And then immediately before that, there's another infix that helps somewhat describe the target class. It's not super specific, but for example, you can have an infix of T or TU, and that refers to a tumor. So an agent like trastuzumab, the TU means it's targeting a tumor. There's other infixes too, where it can be C or CI, is referring to a cardiovascular agent, or L, which denotes an immunomodulator agent like in nivolumab. And then preceding those infixes, then there's really no set nomenclature. That part is kind of made up by the industry and what would flow well for the rest of the monoclonal antibody. So for an example, just to put it all together, trastuzumab, you have a humanized monoclonal antibody that targets tumors. Of course, the naming conventions are probably undergoing revision over time, so we may notice these changes in the future. But so far, it seems like, at least with the more recently FDA-approved monoclonal antibodies, that they're still keeping that naming convention for now.
Thank you so much for reviewing that. I agree. It's fascinating when you understand the pieces and parts of what goes into that non-proprietary name. It does give you those clues. And so if you know what that means, then you can start to make some assumptions, some guesses about, like you've already mentioned a little bit, like, are they going to be more likely to have sensitivities or reactions to this drug based on the source that it was created from? And so those can be even just initial clues for, as nurses, if we're seeing a drug for the first time. If we know what that breakdown means, it starts to give us some of that information, even in the very early stages of learning about a drug. So thank you for reviewing that. So let's talk a little bit more in detail about the mechanism of action of how monoclonal antibodies work.
So monoclonal antibodies work through a kind of complex variety of mechanisms. So I think before understanding how it works, it's important to understand the structure and also that there are different subclasses of antibodies. They all have different letters. So you have IgG, IgA, IgD, E, and M. They all have different functions and different shapes, but our kind of therapeutic monoclonal antibodies are typically IgG based. These have kind of much more simple monomeric structure, so just made of one subgroup, and they have fairly high affinities for their targets. So a lot of the therapeutics we use fall within this class. But even within the IgG class, there are many more subclasses. And then when we think of that kind of classic antibody kind of monomeric shape, so structurally, antibodies are these Y-shaped molecules. They're composed of 4 fragments. They have 2 identical light chains and 2 identical heavy chains, as I try to describe this without an actual picture. But the heavy chain sort of looks like a hockey stick or a boomerang shape, and they're linked together via disulfide bonds. Those 2 create the Y shape of the antibody. And then we have these light chain components that are much shorter and smaller in nature. And those are kind of nestled underneath those V parts of the Y tip. And so the top part of the Y, the V part of that Y, makes up what we call the variable region. So this is where our antibodies get all their variety and where they're able to target all different kinds of target. This is also the site where our antigen binding sites are found. So the site on the antibody that is going to bind the antigen is called the paratope, whereas the site that it binds to on the target is called an epitope. And then we have the bottom part of the Y. This is the constant region of the antibody, also called Fc binding region. This part of the antibody can bind to various effector cells, where this is where the antibody is eliciting a wider range of responses. And those responses are going to depend kind of on what's being targeted and what they're binding to. So there can be a variety of different kinds of effector cells. One of the mechanisms is where they are able to cause tumor cell death by binding to and blocking 2 necessary growth factor signaling pathways for tumor cell survival. So that's going to be kind of dependent on the target of the antibody. But essentially, I'll give an example of EGFR, or epidermal growth factor. This is overexpressed in several different kinds of cancers, where activation of this growth factor increases the amount of proliferation and migration of cancer cells. So if we bind to it and block to it, then that would help halt these pathways and stop cancer cell growth. Another way that they work is through a process called antibody-dependent cellular cytotoxicity, or antibody-dependent cellular phagocytosis, and that's going to depend on what cell we're binding to. So you can have that Fc binding region of the monoclonal antibodies binding to the Fc receptors of different kinds of immune cells like NK cells, neutrophils, monocytes, macrophages. And depending on that type of cell you're binding to, then you can get factors that are released and that promote apoptosis, cell lysis, or phagocytosis. And then lastly, you can also get activation of the complement system caused by these antibodies. And so the complement-mediated components, there's something called opsonins, which work to bind to the surface of the targets. And they essentially serve as find-me signals or markers for destruction by other components of the system. And then they can also, through this complement-mediated pathway, they can form something called the membrane attack complex, which ultimately causes lysis of the target cells. So there's all these different mechanisms that the monoclonal antibodies can take advantage of to ultimately cause that cancer cell death.
Seems a little unfair to ask you to describe the mechanism of action of a monoclonal antibody without visual aids and diagrams. Excellent job, though. Absolutely fantastic. And really helps paint that picture of just all the variables that are included in this molecule and how it allows it to work in so many different and unique ways. And so I really appreciate your willingness and ability to say that, to speak that to us and help us visualize that, because I do think it's important. I do think it helps us to have a clearer understanding of what exactly it is we're dealing with here. And then ultimately that translates to how we can educate our patients.
Yeah, absolutely. And having a picture is always helpful. You can always Google a picture, find it, and kind of correlate with that.
So let's talk a little bit now about some of the primary subclasses in this larger monoclonal antibody class. And maybe you can highlight a few examples of some of the newer agents that we might be seeing.
So thinking of subclasses, first we have kind of our traditional monoclonal antibodies that have a singular target. Some I've already mentioned before, but these include things like rituximab, which targets CD20. We have trastuzumab, which targets HER2, cetuximab, that targets EGFR. These really have their anti-tumor activity in the mechanisms that I described above. Some of the newer ones that I've alluded to include antibody drug conjugates. So we have a monoclonal antibody targeting that's kind of a similar target, and that's then linked to a chemotherapy agent. So the whole goal is really to deliver the chemotherapy in a much more targeted manner and to minimize adverse effects. So the antibody is going to bring that cytotoxic payload to the target cancer cell where the whole molecule gets internalized and then the chemotherapy gets released from its linker, causing tumor cell lysis. But you still have to remember that we are still giving chemotherapy. So once that cell lysis occurs, that chemotherapy is kind of just still spilling into the bloodstream. So it still can have those systemic effects. Some examples of these drugs include things like brentuximab vedotin. This particular antibody drug conjugate is targeting CD30, which is found on Hodgkin lymphoma cells. Then it releases the chemotherapy component. The vedotin component is a microtubule inhibitor cytotoxic payload. And then another more recent example, there's a recently FDA-approved datopotamab deruxtecan, which is used for breast cancer. This has a target of TROP2, and then it brings in, and its cytotoxic payload is a type of topoisomerase inhibitor. And then from there, we also have bispecific antibodies. So this is where the monoclonal antibodies are able to recognize two different targets. One of the targets for it is a target found on T cells. So it typically binds CD3, so that's the T cell target. And then it targets the tumor cells. So typically the ones we have on market are either CD19 or CD20, which is found on B cells. So essentially these help redirect the T cells towards the cancer cells, and that is able to elicit their tumor cell killing. But there are also bispecific antibodies that can simply recognize two targets. It doesn't just have to be a target on the T cells. So we have a drug such as amivantamab for lung cancer that does recognize two targets. It recognizes EGFR and MET. And then even beyond that, there are even newer technologies that include something called a nanobody. These are actually just fragments of IgG antibodies, and they're made of only heavy chains. So they're much smaller in size as well. They're thought to have better stability. So theoretically, one day they'd be able to make one that is orally administered. They're supposed to have improved tissue penetration to really difficult to reach areas. So a lot of the biologic monoclonal antibodies that we have are really large in size. And so it's difficult for them to penetrate the central nervous system due to their size. But this nanobody technology is supposed to help overcome that because they are much smaller. And so the first FDA-approved antibody using this technology, and the nanobody technology, I believe, is trademarked. But the first one ever is called caplacizumab. That was FDA approved in 2017 for acquired thrombotic thrombocytopenic purpura. And then there's even further areas of investigation, such as looking at trispecific antibodies, so antibodies that have three different targets.
Just when you think it can't get any more complex, the next new thing comes out. But how exciting, and what a fascinating specialty to be in when every week it seems like there's something new for us to continue to learn and provide to our patients that is just that much more specific and really to help improve those outcomes. So thank you for talking through all those variations with us. Now, we spoke earlier about sort of the naming convention of monoclonal antibodies, but there was one piece that we didn't quite get to, and it kind of relates to the difference between what we know in chemical drugs as a generic formulation and what we see in monoclonal antibodies, which is a biosimilar. So can you explain the difference in those when it comes to monoclonal antibodies, and how does that influence the name of that drug?
So, a generic drug is determined to describe a drug that has the exact same chemical structure as the initial reference or branded product. The only difference is really in the excipient. So, the active ingredient is exactly the same. So, we can do this with our traditional kind of chemotherapeutic agents or traditional drugs because the chemical structures are really very simple and a lot easier to replicate compared to a really large molecule like monoclonal antibodies. And these monoclonal antibodies are also made from living cells. So it's a lot more complex technologies. So they can't get the exact same product as the reference or branded product. So instead of that, we have a product that is highly similar, what we call biosimilar to the reference product. And although it's not exactly the same, by being a biosimilar really should have no clinically meaningful differences. So they do undergo a number of tests and studies that look at purity, potency, pharmacokinetics, and pharmacodynamics, efficacy and safety, as well as immunogenicity to determine that these are, just as good or highly similar to the reference product. So they have to demonstrate comparable efficacy and safety. So that's why we have biosimilar products and we don't really have generic monoclonal antibodies. And then something about the names that you'll notice, and you'll also notice with kind of newly approved monoclonal antibodies as well, even with the original reference brand product, is that they're going to have different four-letter suffixes to distinguish them from the proprietary product. There's no specific rhyme or reason. They just have four separate letters just to help distinguish the products. So now that these products, like rituximab, have been on the market for longer and longer, we're starting to see more and more biosimilars come out.
Wonderful. Thank you for covering that. I think we have seen biosimilars now for long enough that I think we're familiar with them, but it is something that is an important distinction. And we often get questions from patients of like, oh, is this just a generic? And I think it is important to be clear that it's a little bit different than what a generic drug means for those chemical drugs. But again, for the outcomes, for the efficacy, patients can be reassured that the product should be providing the same outcomes as the original product. But important to note that. And then again, just to make the drug names more complicated, let's add a meaningless four-letter suffix on the very, very end, just to make it a little bit more confusing. But knowing what that means and being able to provide that information to our patients just can help them be more aware of what drug they're getting. I think that's important education to provide to them. So let's move on now and talk a little bit about some of the testing we might see before a patient is prescribed these types of medicines or is deemed eligible to receive them. What types of biomarker testing would we typically need before a patient could be prescribed a monoclonal antibody?
For this, I would say that there's no one biomarker testing we're doing that's common to all the different monoclonal antibodies. It's really going to be dependent on the disease state that's being treated. For example, some of our agents are HER2 targeting products. You would probably expect there to be some testing to confirm HER2 positivity and maybe our gastric or breast cancers before starting an agent like trastuzumab. But again, it's going to really depend on the specific malignancy. Another example is with our immune checkpoint inhibitors. Some of the oncologic indications we have find benefit in patients who have certain types of expression or a certain percentage of expression of PD-1 or PD-L1, or they're looking at mismatch repair mechanisms. So it would only be indicated for these patients. But there are some cancers where you don't even check expression at all. So that's really going to be dependent. There's also some treatments out there that generally you can use only if they don't express a certain type of biomarker as well. So there's kind of like the flip side way to think of it. And then nowadays we do have treatments that are also considered tumor agnostic. This is when a patient has a certain biomarker, then that treatment can be given and that FDA approval was given regardless of what type of tumor the patient has. We typically see these kinds of tumor agnostic therapies more so in patients who have recurrent or advanced diseases in solid tumors. The one monoclonal antibody example that comes to mind is with dostarlimab. That's a checkpoint inhibitor that's approved for patients who are deficient in mismatch repair mechanism. It's also called DMMR.
That's great. And again, it does highlight the diversity of this drug class, and maybe a recurring theme we might be preaching for the rest of the episode is review the package insert. Understand what drug you're giving, understand the details that are specific to that drug, including if there are biomarkers to be tested or eligibility kind of criteria that would indicate a patient is appropriate to receive this type of drug. Every drug will be so different. And so it is always important to review that package insert and just understand what drug you're giving.
100% agree. That's something I always tell learners when they come into the oncology field, that package insert honestly is such a great way to get a quick summary and overview of all the information that you need to know.
So let's talk maybe a little bit, if we can, just about, are there any common toxicities or adverse events that we see maybe broadly across the monoclonal antibody drug class? And are there any individual agents or subclasses with any notable toxicities that you would call out?
The one side effect I can say that is fairly common to all of these would be the risk of infusion-related reactions, depending on the actual product. That, of course, can range in severity, but the overwhelming majority of these monoclonal antibodies usually do mention infusion-related reactions or to be one of the warnings or precautions or side effects to monitor for. The severity of the reactions can vary widely, ranging from self-resolving pruritus or nasal congestion or hives, all the way to patients having risk of anaphylactic reactions. The risk of reactions can also not only just depend on the actual monoclonal antibody product we're giving, but also on the disease state we're treating. So, for example, if we're going to use rituximab to treat a newly diagnosed diffuse large B-cell lymphoma where they have a lot of disease burden, they're more likely to have a reaction versus another kind of off-label indication that rituximab is used for is for something like EBV viremia. So for treating that kind of infection. So from what we've seen is that the risk of reactions is much higher in that patient with kind of higher burden of disease and treating actual malignancy. And then also the murine-based monoclonal antibodies tend to be more immunogenic than the newer kind of humanized or chimeric monoclonal antibodies. For the other common toxicities and adverse events, I think these are really just kind of depend on their specific targets. So I've been using kind of immune checkpoint inhibitors as an example. So just briefly, our immune system constantly has the surveillance system, and they're able to recognize foreign pathogens, like I mentioned, or abnormal cells, and even precancerous cells, and they're able to eliminate them before they become cancerous. But then on the flip side, one of the regulatory mechanisms that we have, so our own immune system doesn't attack itself, is the presence of checkpoints. One of these checkpoints is PD-1 or PD-L1. So when these checkpoints bind to their ligands, this can then act as an off switch so that, again, our immune system is not going to attack itself or attack different parts of our body. But then the tumor cells can take advantage of this and actually use this mechanism to evade the immune system. So when we're giving a checkpoint inhibitor, now we're removing that off switch. And then as a consequence, common adverse effects can include things like immune-mediated adverse events. These most commonly affect things like the skin, gastrointestinal tract, and liver. But essentially, this can cause any itis that you can think of and an inflammatory response of any organ in the body. So we have these kinds of mechanistic side effects that are called on-target, off-tumor effects. And then another example that I could talk about too is like with HER2, because I mentioned trastuzumab. HER2 is not unique to tumor cells, but it's also found on cardiac myocytes. That's why a drug like trastuzumab can cause cardiotoxicity because it is HER2 directed. So that's kind of with like the more traditional types of monoclonal antibodies. And the same kinds of concepts do apply to antibody drug conjugates, except now when you're thinking of the toxicities, you have both the target of the agent and also the chemotherapy that you're looking at. So for example, one of the cytotoxic payloads of the chemotherapy components is vedotin, which is a type of microtubule inhibitor. And there's brentuximab vedotin, there's polatuzumab vedotin, but you'll see that because of this microtubule inhibitor component, that peripheral neuropathy is a shared toxicity. And the same kinds of concepts apply to bispecific antibodies as well. It's not just limited to monoclonal antibodies, but this kind of concept of these kind of on-target off-tumor effects can be applied to any of our existing therapies.
As we said before, check the package insert.
Yeah.
It will tell you all the important details, and we joke about that, but truly it's a great source of information. And even in this short episode, it's already so much information that any one person can hold in their brain at any one given time. And so it really is an important sort of singular source of truth that we can look to, reference, even if we think we know the drug we're about to give, like the back of our hand. It never hurts to review that because those package inserts are also updated. If information comes out and it changes anything, those are also updated. So it is important, even for those of us that have worked in oncology for a very long time, incorporate it into your practice of reviewing those regularly so that you can be sure that you have all the most current information at your fingertips. So let's talk briefly about if there are any pharmacologic related strategies that we can use to prevent some of these toxicities, either prevent or manage the toxicities that you've just mentioned.
With the recurring theme that this is going to be something that will depend on the agent. Using the same examples, kind of looking at strategies to prevent infusion reactions. One example is the use of premedication. If premedication is recommended, this typically includes any combination of antipyretics, which is typically acetaminophen, and histamine, which is typically an H1 antagonist like diphenhydramine. Although there could be cases where we want to substitute this agent because maybe the patient has been tolerating therapy okay and they're having a lot of side effects. So we might use a second generation antihistamine in some cases. The premedication may be given with or without some kind of steroid, whether that's methylprednisolone, hydrocortisone, or dexamethasone. And then some other agents that have higher risk of reactions, they may employ agents such as montelukast or H2 antagonists like famotidine. Another strategy to try to prevent infusion-related reactions could be splitting the dose over a couple of days. So one example is obinutuzumab, which for certain indication to minimize the risk of infusion reaction, the total dose is 1,000 milligrams, but they will only give, for the first cycle at least, 100 milligrams on day one, and then the remaining 900 milligrams the next day, instead of giving the whole dose in one day. Other strategies include gradual titration of the drug, especially with the first infusion. So rituximab is one that has kind of a slow, gradual titration with the first dose, and then you can kind of speed up the titration with subsequent doses. And then some antibodies may have a recommended period of observation as well after the infusion is complete, just to watch out for any a little bit more delayed reactions. And then again, not all infusions are going to carry the same risk. So some of the precautions might vary. Some of these antibodies might not have any additional precautions other than just watching them during their infusion for any reactions as well. So again, really going to be dependent on the product. And then just to give another couple other examples, kind of using the same examples that I previously mentioned. So thinking of trastuzumab and that risk of cardiotoxicity, one of the things that we're watching out for is that risk of cardiotoxicity. So they're going to check an echo or a MUGA scan to monitor that ejection fraction every 3 to 6 months. And then when we're thinking about the checkpoint inhibitors, we don't really have prophylactic measures at this time, but we are routinely monitoring a wide variety of labs and watching out for those itises that can happen. So assessing for transaminitis, looking at AST, ALT, assessing for thyroiditis, so checking a TSH, checking for pancreatitis, amylase lipase levels on top of our kind of traditional like CBC, CMP that we gather.
So let's move on now a little bit and just briefly discuss how these drugs are actually given. Talk to me a little bit about some of the administration considerations that nurses should be mindful of when we are giving our patients monoclonal antibodies.
In most cases, the monoclonal antibodies that we have in oncology are going to be given as an IV infusion. For these, again, duration, premedication, observation periods, all that's going to vary by products. In general, all these products should be administered in their own dedicated line. Some of the products might require a filter, so best to refer to the prescribing information or the package insert for each product. More recently, there have been some different ways of administering it. Specifically, they've been developing subcutaneous formulations of monoclonal antibodies. So typically, when we think of a subcutaneous injection, we generally have a max of maybe about 1.5 to 2 mLs per injection, just for comfort reasons. It's a pretty big volume to give already for patients. But these antibodies, they're a lot larger molecules, so they do require larger volumes to administer the full dose. So to overcome this limitation, they end up co-formulating these antibodies with hyaluronidase. So what hyaluronidase does is that it's going to dissolve the hyaluronin proteins found in the connective tissues, and that helps expand and allow expansion of the tissues to allow you to inject more fluid. This can be really beneficial for people who have difficult IV access, and it can also save chair time. So sometimes it brings, I'm just thinking about the kind of one of the newer subcutaneous products that was approved, which is nivolumab hyaluronidase. So instead of a 30-minute infusion, it's like about a 3 to 5 minute injection. So it can definitely save on chair time. Some other products that we also have subcutaneous formulations for include rituximab, daratumumab. There's the trastuzumab-pertuzumab combination. And then, like I mentioned, a few of our checkpoint inhibitors now have kind of newer FDA-approved subcutaneous formulations.
The transition to subcutaneous has certainly been pretty revolutionary for all the reasons that you mentioned, most notably of yes, the chair time, and also just that time toxicity that we know patients face. And, that's time away from whether it's just being at home, being with their families, being at work, if they still feel able and well to be able to work during their treatment. And so certainly a benefit for patients for all of those reasons, but also then brings challenges for us as clinicians of, okay, we don't get to see them for as long. And so how do we make sure that we talk to them about all the important information that they might need to report on when they go home, since they're going home so much more quickly after that infusion? But great points to bring up. Kind of leads us to our next question. What are some of the primary education points we should be providing to our patients after they receive their monoclonal antibody?
Again, going to depend on the product, but taking into consideration the checkpoint inhibitors that I had mentioned, you definitely want to educate patients on the most common side effects and also the side effects at which we feel, there's a lot of risk. We want to educate them as to when they should be calling the clinic. With immune checkpoint inhibitors, you definitely want to educate them on the risk of those immune-mediated side effects. For example, the colitis that can happen. You can tell them that you want them to call the clinic if they have more than 4 or 5 loose stools per day, or for the rash that can happen, I'll definitely call if you have a diffuse rash. That would just be some examples of counseling points. Some of the infusions that we give as well could have possibility of a delayed infusion reaction. So definitely educating patients on the signs and symptoms of infusion reactions that they might expect as well. And then I do have a couple of personal favorite websites where I get my patient education. One of them is kind of a collaboration of HOPA, ONS, ACCC, and I think it was NCODA.
Encoda?
Encoda, yeah, which they collaborated. And I really do like the patient education sheets that they have put together. And then another website that I do really like is called Oncolink. So it's just another website that puts together a list of all the relevant adverse effects and really highlights them and discusses them in a much more digestible way. So I feel like it's really helpful for patients to just have a handout because it is a lot of information to remember off the top of your head. So, or just hearing it for the first time, it can be overwhelming. So I think it is helpful to kind of provide some of these handouts.
So, Carissa, how do you see pharmacists and oncology nurses collaborating in your institution to help manage adverse events and toxicities, provide this education that you've just reviewed with us, and really just serving as a trusted source of information for our patients and their caregivers?
I think that we are constantly collaborating and talking to each other all day. It is a lot of information to stay on top of to manage their adverse events, stay up on top of all the necessary supportive care and monitoring and patient education. So thinking about some of those more direct patient care roles, the nurses, and pharmacists, we both, I think, serve as very important double checks for the treatments that we're administering. We're looking at the dose, the treatment plan, does it make sense? When was their last treatment? Are they on time, on schedule? And we're making sure that they are receiving all their necessary pre-meds. Are they staying for the necessary observation times? And I feel that our nurses are really at the front lines, giving patients their treatments, monitoring treatment plans. And sometimes we find that they gather information because the patients are sitting in the chair getting their treatment. And sometimes our patients kind of divulge some more information that maybe they didn't tell us or tell their providers. So then that can really impact their care. So we've definitely had cases where that's happened. And our nurses may notice an issue with the treatment plan that we put together for the patient. Here at our institution, we utilize kind of electronic medical record, kind of like an extra IT system that we use to help making sure we keep track of all the appropriate monitoring. So they may notice problems with the treatment plan that need to be modified and updated. And then on the more administrative, kind of educational leadership side of things, like I mentioned, we are kind of using these IT support systems to make all this care a lot easier. And so we really do value nursing input as we're putting together these treatment plans in case they notice any kind of administration-related items that are maybe worded in an unclear way, if they're missing. And then we also have our nurses who are really directly following these patients, monitoring patients for their adverse effects, where on the pharmacy side, we can kind of help serve as an important drug information resource. And then we can kind of work together to put together education sessions or resources for the team just to help our staff stay up to date of the newer agents that we use in practice.
And then finally, you gave us maybe a few hints earlier, but what do you think the future looks like for these agents and their continued role in the landscape of cancer care?
I feel that monoclonal antibodies now really are like a workhorse agent in cancer treatment, and I have no doubts that will continue to be the case. I do feel in general in oncology, now that we have these newer treatment options, we're trying to move away, if possible, from some of the more traditional cytotoxic chemotherapy. So some of the regimens that we have that are coming out nowadays are even considered chemotherapy-free regimens. So combining monoclonal antibodies with more targeted therapies. And then I also think with a lot of the newer technology, like the nanobodies that I mentioned, we're going to try to work towards developing a product that is logistically easier for patients. Hopefully, maybe one day we'll even have kind of agents that are orally administered and to be logistically more favorable for patients.
Well, Carissa, thank you so much for joining us on the podcast today. As we reach the end of our episode, we'd like to always wrap things up with a few quick questions to help summarize some of the important points that we've discussed. To start that off, how do you think healthcare professionals should be evaluating their hidden or maybe their implicit bias that they hold about monoclonal antibodies?
I think that there is generally perception that monoclonal antibodies are very safe, at least when we're comparing them to traditional cytotoxic chemotherapy. And for sure, they're not toxic in the same ways that chemotherapy is. But I do think it's still important to remember that these agents do have their own unique toxicities. In some cases, can be just as fatal from those adverse effects, or they have really aggressive monitoring and supportive care. So I think it is important to still kind of keep that in mind.
And what are some common misconceptions about monoclonal antibodies?
I think for us, those of us who work in the oncology field, we tend to think of monoclonal antibody usage to be primarily oncology, but that's not really the case because the first monoclonal antibodies that were developed were not even for oncologic indications. They were for transplant indication, for cardiac indication. And so they're really diversely utilized across all specialties in medicines. We have monoclonal antibodies for hyperlipidemia, for neurology, for rheumatology. So the uses are really so very expansive across all specialties.
What's something about this topic that's not often discussed, but you wish people knew more about?
I think one piece to consider with monoclonal antibodies, as life-changing as they have been, they do have a lot of logistical considerations for patients. So some of these therapies do have very extensive infusion times. Some of them are as long as 2 or 4 hours or even longer. Again, they require pre-medication at times, so that also adds time. They also, if they don't have a central line already inserted, then maybe they need to get peripheral line every time they come to clinic. And some people have poor venous access, so that becomes challenging, which causes discomfort. The patient also adds more time, or if they have a central line, that becomes an infection risk. So I think there is a lot of logistical challenges that do still kind of need to be considered. And then sometimes we have multiple monoclonal antibodies that have the same exact target and the same exact mechanism of action with the same indication and no comparative literature available at this time in terms of looking at efficacy. So what we're kind of left with is kind of looking at the differences in logistics of administration, kind of playing a bigger role in determining what's best for the patient.
What additional training or education do oncology nurses need to stay current on this topic?
I think taking up any learning activity that's available, whether it's by listening to a podcast or listening to other professional organization offered learning modules, or if your institution offers any kind of education or learning modules, that's always really helpful. We also utilize our IT support heavily to try to pre-incorporate monitoring parameters, standard dosages, or required labs for different products just right into the system. And so I think you can actually just passively learn as well from kind of reviewing the patient's treatment plans if you kind of have these types of systems in place.
And then I know you already mentioned a couple, but are there any additional resources that you would recommend for patients or for other providers who want to learn more?
The package insert honestly is such a great place to get started. If you wanted to learn more about monoclonal antibody history, manufacturing processes, and newer technologies, there are a couple of articles I did personally find quite interesting, which I think we can link later on below.
Absolutely.
And then, like I mentioned, for patients, those patient education sheets developed by our professional organizations are really helpful and written in such a digestible way for patients to understand their treatments.
Carissa, thank you again so much for joining us today and sharing all of this great information about monoclonal antibodies, something that we as oncology nurses are basically used to seeing every day now, but still worth the pause to really dive deeper into understanding what they are, how they work, how they came to be, as you described, this workhorse in oncology. So thank you so much for sharing all of your wisdom with us today. Do you have any final comments you'd like to share with our listeners?
Monoclonal antibodies have now been around for almost 40 years or so, and there's still so many new products being developed by the FDA. They're thinking of new methods of administration. I think it's an area that's really complex, but I think it's so important that we all work together to really ensure the safe administration of these drugs. But overall, I feel like it's been a really interesting and exciting modality of treatment in the field. So really excited to see what continues to be developed in the future.
Wonderful. Well, thank you again.
Thank you so much for having me.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.